Hello, my name is Ruben Mesa, and I'm the Executive Director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center. And delighted to be joined by this wonderful panel of experts in myeloproliferative neoplasms for us to take a deep dive in myelofibrosis. We're grateful to Blood Cancer Today for us to be able to share with you some of the exciting updates on the diagnosis and therapy of patients with myelofibrosis. Let's switch to fedratinib. So frontline or second line, where do you primarily use fedratinib? Have you used it in the front line? And if you use it primarily in the second line, who do you use fedratinib in?
Okay, that's an excellent question. So I've used fedratinib in the front line only in the setting of a clinical trial. Generally, I have reserved use of fedratinib in the second line based on the clinical trial data that show that the drug is effective in the second line post-Rux failure. And I, like with Rux, I tend to, now that we have these armamentarium of other JAK inhibitors, I tend to favor using fedratinib in folks who have a large spleen, but hematopoiesis is still kind of reasonably well preserved. Because I really do think that it has significant potential to improve splenomegaly even in the second line. And the reason I don't reach for it in the first line is because of tolerability. You really have to kind of have a good, have a patient who's who you educate and who reaches out to you early as they may experience, potential toxicity. There are many reports of people going on and off fedratinib so rapidly, and I think, that really all harkens back to tolerability.
Yeah. Very helpful. I'll share that I have used it in the front line, but specifically in people that are JAK inhibitor naive and had multiple skin cancer issues ahead of time, or had had difficulties with herpes zoster, but were still JAK inhibitor naive. So, a narrow group who have preserved hematopoiesis.
Yeah.
Now the toxicity, can be an issue, as well as there's been the concern regarding thiamine and Wernicke's encephalopathy. Naveen, thoughts on one, where you tend to use it, but two, how do you manage the toxicities?
I think this is an important discussion that you both raised. The fedratinib in the clinic, the major issue has been GI toxicity. When I am prescribing fedratinib, I'm generally prescribing 3 other drugs, guys. I'm checking thiamine as the black box warning indication. You and Claire Harrison did a beautiful analysis where perhaps these were not Wernicke's encephalopathy, but they are encephalopathy NOS, and so these patients are generally older, frail, a lot of our patients. So actually checking the thiamine is important, period. So checking and replacing. 2, nausea is a serious concern for some of my patients, and then 3, diarrhea. So you're giving your antiemetics, anti-diarrhea thiamine. This is a lot. This is at baseline. So now you're following the patients over time, and certainly if someone develops an encephalopathy event, this is a serious event in the clinic. I'm doing MRI of the brain, neurology consultation, et cetera. But it's really GI. That's the main thing. And so I guess that's the only thing I'd like to add, is that is a serious issue. And when I'm counseling my patients, if they have a major GI comorbidity, we may stay away from this drug for that indication.
No, very true. I find that when I use it, I just give patients thiamine.
Yeah,
Right,
that's what I do.
right, regardless, right?
It's thiamine.
Very innocuous.
It's harmless. It's cheap. It can lower the thiamine levels. So I always view that it's a fairly low bar to try to kind of nip that in the bud, if we would.